Hi everyone and welcome back to my channel. So today we'll be discussing about the graft rejection and graft versus host disease. Okay. So first of all, graft rejection. When a donor organ, comes and is attached to a recipient's body, what happens is that the donor organ has certain foreign MHCs. MHCs are major histocompatibility complexes, and these are of two types. It is the MHC1 and the MHC2. Okay, so when this comes in, the recipient actually produces antibodies and T cells against that foreign MHC, and this antibodies and T cells goes and destroys this foreign MHC keeping organ. So this is known as graft rejection. That is why there is a lot of compatibility checking before an organ is donated or transplanted. Okay. So this graft rejection happens by two pathways. One is the direct pathway, another one is the indirect pathway. So in the direct pathway, what happens is that the donor's antigen presenting cell presents the donor's foreign MHC to the recipient T cells. Okay. In this, let me make it easier for you to understand. It is like you see, the direct pathway is like surrendering. It's like surrendering, where the recipient T cells are the polis. Okay, and the donor APCs are the actually the committers or the bad guys. Okay, they did something bad. I mean, they came into a wrong location and they themselves go and present themselves that, okay, we are sorry, we came here, please do your duty. Okay, whereas the indirect pathway is like the polis going and arresting people. So over here also the recipient T cells are the polis, and they go and the recipient's APC, that is the recipient's cells, goes and finds out where these donor foreign antigens are, and it brings them to the recipient T cells. So the T cells which act in the direct pathway are the CD8 positive T cells and the CD4 positive T cells, whereas in the indirect it is the CD4 positive T cells, which give rise to helper T cells, which help the B cells to destroy the transplanted organ. So these organs are there, right? These are otherwise known as grafts, and there are actually four types of grafts. One is the autograft. Autograft is the self graft, that is like for example, if a person undergoes a trauma injury and his face skin peels off, so what they do is they take the inner side of his thigh, the skin, and take it and transplant in his face, I mean that burnt area. So this is known as autograft. Allograft is when a graft tissue is transplanted between two individuals of the same species. Like there's one person being ill, and then there's another healthy person. So what happens, his cell is going and being given to the ill patient so that he may become more smiley. Okay, and the isograft, that is between the identical twins. That is like there are two identical twins and one of them has some sort of a problem, so I mean some sort of organ failure, so that organ is being transplanted from the healthier one to the unhealthy one. So that is isografts. And xenografts, that is a niche topic actually, which is between different species, such as transplanting between a human and I don't know, maybe a pig or maybe a fish, so like that. Okay, so yeah, and then for all these HLA matching is required. That is, HLAs are otherwise known as MHCs. Okay, so the percentage of that compatibility in the HLA matching, is different for various organs. First of all, the cornea's HLA percentage, even if it's 0% of matching, it's fine, because this cornea is there, right? It is avascular, so actually blood supply isn't there, so antibodies won't be able to reach the transplanted tissue. So there's no problem in transplanting cornea. Whereas in the bone marrow, where there is high level of blood supply, okay, and therefore HLA matching should be at the most level. I mean, 100% matching should be there. Whereas in kidney and liver, it should be about 50%, and in the lungs and heart, it is 0%. Why is that so? Actually, the lungs and heart also have high, blood supply, but as you know, these lungs and heart cannot be, received from a living patient, which if we, receive that is illegal. And another thing is that, it is. It's like killing a person, right? It is actually killing a person. So only these dead patients or these coma patients, from them these organs are extracted. So since there is limited availability of these organs, so 0% is there. So how is this graft rejection occurring? What is its mechanism? See, on the basis of timing, we can differentiate the mechanisms, okay? First one is the hyperacute. Other one is the acute and the chronic. The hyperacute is, within minutes and hours. Why is that? That is because the recipient patient is there, right? He has preformed anti-donor HLA antibodies. That is, this recipient has antibodies prepared. It's like pakka prepared and ready to go and attack the the transplanted organ. Yeah. So that is majorly mediated by the type 2 HSR. HSR is hypersensitivity reaction. Type 2 is otherwise known as the antibody type. As you can see, the antibodies are already prepared to fight. Okay. The acute occurs within days and weeks. Okay. That is, this hyperacute occurs during transplantation itself, whereas the acute occurs after the transplantation. So the acute can be mediated by two ways. One is the type 2 hypersensitivity reaction, and the type 4. Type 4 is the cell type. Okay, T cells are mediated to go and destroy the to destroy the graft, or the antibodies are created. Whereas the chronic, which takes months to years to cause this transplant rejection, that is also post-transplant, and it is mediated by the type 4 hypersensitivity reaction, that is the T cell mediated. Okay. And so there are various biopsy things which we can observe. The first one, in hyperacute, we can see neutrophilic infiltration. Why is neutrophil? Because as you know, neutrophils mainly constitute during an acute inflammation. That is the inflammation which occurs instantly. Okay. And the fibrinoid necrosis. Because of all these complements, what happens is that fibrinoids are produced, and that decreases blood supply to that organ and causing necrosis. Okay. And thrombotic occlusions of vessels also occur. As you know these platelets are formed, plugs are formed and clots are formed, which go and when there's a blood vessel, these go and occupy and actually inhibit the blood supply, thereby causing degradation of this thing, thereby causing thrombotic occlusion of the vessels. So this is an example of the fibrinoid necrosis. Okay. Now the acute is there are two types, right? One is the antibody mediated, another one is the T cell mediated. So in antibody mediated, there is C4D deposition in the capillaries, which is specific. Okay, why is that so? Because C4D actually has a long T half. I mean, T half. Okay, whereas other complements like the C3D or C3, C5, C6, C7 all have a longer T half, therefore get broken down. So yeah, and then the T cell mediated. In T cell mediated, what the major findings what we can see is endothelitis and the tubulitis. What does it mean? The endothelium is inflamed and the tubules are also inflamed in it. In chronic, we can see tubular atrophy and the interstitial fibrosis. Okay, this is an example of the interstitial fibrosis. Okay, so what is the treatment? Okay, graft rejection is happening. So what is the treatment or how to prevent it? The first one is immune suppression. You see, when you suppress the immunity, what happens is these antibodies, these T cells and all production decreases, right? It decreases, and thereby the chances of the organ being rejected is very minimal, and there is supportive therapy. Whereas if there's neutrophilic reactions, anti-neutrophils, something like that should be given, or so like that. Now let's get into the graft versus host disease. It is also known as the Runts disease. Okay, it is seen in these stem cells or bone marrow transplants and during solid organ transplants. So what happens is that these immunocompetent donor T cells are there, right? What happens? I mean, after transplantation, the donor is given immune suppressions. I mean, immunosuppressants are given, right? Therefore, their total immunity itself decreases. Okay, and so they are very much susceptible to infections. When your immunity is low, you get a lot of infections or diseases. So what happens is that you see this donor organ is there, right? Donor organ. That organ constitutes of antibodies and T cells, and that will go and attack the donor cell. It is not actually the donor attacking attacking the it is not the donor attacking the recipient. It is actually the recipient organ attacking the donor cell, donor person, a donor patient actually. So yeah, and that occurs in two ways. First one is normal tissue is being destroyed. The recipient antibodies and T cells go and destroy the normal cells of the donor. That is Gvhd or graft versus host disease. And the other thing is tumor cells are destroyed. You see, this recipient cells are actually abnormal cells, right? It is somewhat different than the recipient cells. So these are actually abnormal, and they might cause tumors also. So what happens is that these organs, right, these antibodies of these organs goes and destroys these tumors. That is actually known as graft versus tumor effect, and that is a really, really good thing. And actually, an organ transplantation is said to be a success only when a graft versus tumor effect is observed. Okay, so what are the clinical findings during graft versus host disease? The first one is, the most common features are the skin rashes and the erythema that is observed in the skin actually. So yeah, this is a common representation of a rash. And then in the liver, cholestatic jaundice is observed, and in the GIT, bloody diarrhea is observed. To reduce the possibility of graft versus host disease, we use immune suppressed donor T cells are given gamma irradiation. So this, what happens is, when it's done, it will increase the reoccurrence of the tumor in the host. What it does is, these donor T cells or these donor organ is there, right? In those donor organs, these antibodies and T cells are there, right? This gamma radiation goes and destroys these. So what happens? So that is a good thing. It won't cause GvHD. It won't cause GvHD. But what it might, give an increasing chance of risk of reoccurrence of the tumor in the host cells. Okay. So yeah. So this is a detailed explanation on the graft rejection and graft versus host disease. And I hope this lecture was really useful for you, and make sure to share it with your friends and spread the knowledge. Thanks for watching. Leave a like, and please do subscribe if you haven't, and let me know if there's any doubt in the comment section. Thanks for watching, and as always, be awesome.